Pulmonary Function Tests, or PFTs, are the definitive clinical tool for evaluating a patient's respiratory mechanics and airflow limits. Physicians rely on these metrics to diagnose respiratory diseases, precisely quantify their severity, and track how a patient responds to long-term therapy. Specifically, the data separates obstructive from restrictive lung pathologies, providing an exact mathematical baseline to assess a patient's preoperative risk. The core challenge is that a patient's true respiratory reserve is invisible from the outside. Without measuring the physical mechanics directly, it is exceedingly difficult to predict their risk of respiratory collapse under physiological stress, such as general anesthesia. Because of this, PFTs rely on forced respiratory maneuvers. These actions cause sudden, massive shifts in intrathoracic pressure, meaning the test itself carries strict medical contraindications. The procedure must be avoided in patients with a recent myocardial infarction, unstable angina, a current pneumothorax, known aneurysms, or recent thoracic and ophthalmic surgeries. PFTs are not passive observations. They are mechanical stress tests. They physically push the cardiopulmonary system to its absolute physiological limits to expose vulnerabilities before an operation begins. Spirometry is the most commonly performed pulmonary function test. It captures a dynamic measurement of airflow and lung volumes over a specific duration of time. To yield valid data, the patient must follow strict procedural rules. First, they must inhale maximally, filling the lungs completely. Second, they execute an explosive, unhesitating start to their exhalation. Third, the patient must maintain that forceful outward push for a minimum of 6 seconds. Finally, they rapidly inhale back to full capacity. The resulting data is highly sensitive to user error. Even a slight hesitation or a single cough during that critical first second of exhalation completely invalidates the test. Without a flawless, explosive physical effort from the patient, the spirometer cannot accurately map the true physical dimensions of the airway. This graph maps the basic spatiotemporal dimensions of human ventilation, starting here at a baseline state of quiet breathing. That rhythmic wave is the tidal volume. It represents the amount of air moving in and out during normal resting ventilation. In an average adult, this is roughly 500 milliliters per breath, or 6 to 8 milliliters per kilogram for pediatric patients. When a patient inhales to their absolute physiological limit, extending far past a normal resting breath, the graph spikes upward. This large upper section is the inspiratory reserve volume. It measures the maximum additional capacity a patient can inhale beyond normal inspiration, typically between 3.2 and 3.6 liters. The inverse action occurs when the patient forces air out of their lungs past a normal resting exhalation. This creates the expiratory reserve volume. It measures the maximum additional capacity a patient can exhale after a standard expiration, resting around 1.2 liters. Together, these three distinct stacked sections represent the visible, dynamically measurable boundaries of human ventilation. But spirometry has a strict physical limitation. No matter how forcefully a patient exhales, the lungs are never entirely empty. A permanent reservoir of air stays behind to keep the alveoli open. This is the residual volume. Because this air cannot be exhaled, it cannot be measured directly by simple spirometry. To understand total lung function, clinicians combine two or more of these static volumes into mathematical capacities. The most prominent is the vital capacity. Vital capacity is the total lung capacity minus the residual volume. For an adult, it measures between 4 and 6 liters and correlates directly with a patient's physical ability to take a deep breath and produce an effective cough. By adding the tidal volume and the inspiratory reserve volume together, we define the inspiratory capacity. This 3.6-liter block represents the absolute largest volume of air a patient can inspire, starting from a normal resting expiratory level. Calculating it is particularly useful for detecting obstructions in the extrathoracic airway. Spirometry maps the functional limits of an active breath, yet the residual volume, the portion of the lungs that remains permanently out of reach, serves as a hidden, pivotal variable for diagnosing severe lung pathology. We must also evaluate the volume of gas remaining in the lungs during normal, passive expiration, completely independent of forced effort. This baseline resting state is the functional residual capacity. calculated mathematically as the sum of the residual volume and the expiratory reserve volume. FRC performs critical physiological work. It maintains the body's oxygen reserve between breaths, prevents alveolar collapse, and allows continuous gas exchange to happen uninterrupted. Several conditions mechanically compress the chest wall and reduce a patient's FRC. These include obesity, pregnancy, simply lying in a supine position, and the induction of general anesthesia. When a reduced functional residual capacity fails to keep the airways propped open, the microscopic architecture fails. Clusters of alveoli rapidly shrink and deflate. This widespread alveolar collapse causes perioperative atelectasis. For the anesthesiologist, this physically translates to rapid, dangerous hypoxia during surgical induction. Functional residual capacity is not a theoretical data point. It is the structural anchor keeping a patient oxygenated and alive while under general anesthesia. This matrix compares how pathological lung diseases mechanically distort the baseline volumes of a normal lung into opposed, highly predictable patterns. In obstructive conditions like COPD and asthma, the patient struggles to expire air. This leads directly to severe air trapping. As air gets trapped with every breath, the residual volume physically expands, pushing upward and diminishing the usable respiratory space in the lungs. Restrictive lung diseases, such as pulmonary fibrosis, cause the opposite mechanical dysfunction. Due to restricted parenchymal compliance, the lung cannot expand. This fibrotic restriction forces a uniform downward reduction in the total lung capacity. We can see the final effect on vital capacity across both pathologies. The measurable respiratory space is sharply reduced in both diagnostic columns. This is the central mechanical paradox. Vital capacity decreases in both diseases, but for entirely different physical reasons. Obstructive disease crushes the usable space from below with trapped air, while restrictive disease squashes it from above with stiffened tissue. Differentiating these structural shifts in static volumes, especially the hidden residual volume and the functional residual capacity, provides the precise data required to interpret spirometry